All right, we're going to break down the piriformis idea as easily as we can. So piriformis can definitely control rotation of the sacrum. It's important because this sciatic notch here, where the piriformis runs on the way to the trochanter of the femur, anterior portion, so you can see it goes the inside of the sacrum bone, has potential to pinch on sciatic nerve, also the sciatic artery come through here. So any change, any rotation of the pelvis, so what we're seeing here is posterior, and pelvis is moved posterior inferiorly this way, and it is gone externally. So the PSI is that bone you feel, dimple of your back, might feel a little farther away, might be a little gap here, it might be a little bit of inflammation, might be feel like a bruised apple. That might be where the irritation is, because it could strain a lot of things. We have attaching here on the sacrum, rim of the pelvic bone, is your lat muscle, and that also attaches on the spine there as well, going up to the arm, so that could strain that. There could be a tear in that tendon. On the other pelvis, we have an ASIN, so the pelvis is shifted the exact opposite direction, and that could be jammed up. It could feel jammed. Might not be painful. Just because it's getting jammed doesn't mean that we're going to feel that pain there. It's just going to be more restricted. Sometimes the more restricted side is not the side that's injured. It's the side that is getting tugged on. So we're going to see on the ASIN side that the sacrum will rotate toward there. And you just think about that pelvis shifting up. What's going to do to the femur? It's going to drive it down. This might be the long leg side. Not always. Sometimes it could be short. But when we bend the knee, it'll be long. So it'll recorrect itself. That usually indicates there's some sort of neck problem going on. Not necessarily, but our focus here is to work the pelvis the best we can. So obviously the short leg side is going to be on the left. Longer leg side might be on the right. But that might look differently depending on what position you are in. But generally standing, that's how it's going to look. And you might see that pelvis a little higher on that right side. Posterior side is rotated back. So the longer the leg tends to hike up the one side. So a bit more here on piriformis syndrome. So added rotation of the sacrum. So we can think about the sacrum coming posterior on the right side in this pattern. And that is actually going to overstretch the piriformis muscle, because we think about that ASIN going this way, it's actually driving the trochanter, the femur downwards, giving that appearance of that longer leg. And the interesting thing is sometimes standing, I added this with the iliac crest. So that's this bone here is the iliac crest. PIEX, ASIN, it could look like that iliac crest is going to be higher up. So it might even look like the hip is higher on the left, but go by the femur heights. Really, you want to check the trochanter, see which one is higher there, or just do a leg check when they're laying down. That's a little bit more reliable, but just in case you see that pattern, sometimes you think, well, it looks like that iliac crest is higher, it must be lat tightness. That's probably the anterior rotated pelvis. Just double check yourself there. Watch out for that, because we're getting distortion in the spine with all of this, so we want to check that. So in this pattern, I'd say, well, the sciatica, would probably be over here, because that's the top muscle, because that left one's going to be in a nice short position. So as that sacrum rotates this way, anterior on the left, it's going to have that femur head, the trochanter, closer, and that's just in a nice shortened position. And if you think about this, rotating posterior exterior is not going to be a problem. But if the ASIN comes up, that's when it can really push that ilium, drive that sciatic nerve into the piriformis muscle. And with piriformis syndrome, there tends to be an abnormality, some sort, where the nerve goes through the muscle. That could also be a common thing, but other things you might see there. Facet syndrome is also really common here. So if it's not piriformis syndrome, you might even be looking at some sort of disc issue, because it could be one of these lower lumbar discs, or irritation of the nerve root here. Those nerves come out through here, come out through these holes, and they go down the leg, right? So the problem could be disc related too. So you can see just with the L5 here that I've added that you can sometimes get that facet syndrome on the right. So we need to do different exercises to address that as well, get that capsule stretched out and reevaluate these muscles. Hopefully that gives you a different picture there as far as sciatica and piriformis syndrome and how the sacrum can rotate as well based on what the ilium is doing. So can't really follow the pain on this one. It could be on both sides. Piriformis syndrome, where it's pressing on the sciatic nerve, could be on either side. The nerve can get pinched on the left or the right, because remember, if one side is tighter, and these arrows don't do it justice, but the other side could be more taut. And sometimes it's not the tight piriformis muscle, it's the taut one that's clamping on the sciatic nerve. Ultimately, it's just throwing us off balance. We can see here, this plumb line's not perfect, but we can see that the tip of the sacrum, coccyx, is not going to be central, and that's going to affect everything. It's going to cause curvature in the spine, and it's going to cause pain in the knees, flare of the foot. Everything can fall apart based on what we're seeing here with the sacrum and this piriformis muscle. Obviously, there's a lot of other different muscles working with this. We not only have the piriformis that can cause rotation of the sacrum, but the big one is the one that everyone really thinks about just because it's location close to the sciatic nerve. Hamstring's a big player here. Obviously, if the pelvis is rotated posteriorly, hamstring attaching here to the ischial tuberosity is going to be pulling it downwards, right? It's going to pull it more posterior. Externally, I have to think about too. If it's externally rotating, we're going to have other problems going on in the pelvis. Like we said, the lat usually is going to be receiving some strain there, so it could be taut, could feel tight to you, but usually tighter lat, hypertonic short tissue is going to be on the AS side, because that's going to be more the anterior pelvic tilt. And it's not just both going anterior. We can have one going one way and one going the other way, and even within that, you could have it generally more anterior or generally more posterior, both bilaterally working together, but we can also have a unilateral imbalance. This is all about rotational imbalance. It's trying to fix that, not necessarily trying to fix the general pelvic tilt. That's the rest of your exercises that you should be concentrating on. This is getting torsion out of the spine, torsion out of the pelvis, bringing everything to balance. And sometimes we need that more than we need to work on general pelvic tilt. So another thing we could have here is quad tightness. The quad attaches to the front, the ASIS, so that could pull that pelvis down further anteriorly. And it's just sometimes the structure will determine the muscle patterning. It's not always that you're overworking that quad and eventually causes that bone to move with it. It could be that the bone got jammed up out of place and the muscles have patterned over time. Doesn't matter. We need to affect the structure, the bony structure. And sometimes that includes the ligaments too. We tend to forget, okay, it's all about the muscles, but there's joint tissue that can become restricted. And there's ligaments as well, especially when we're dealing with the capsule. There's all these ligaments here that are just really holding, that femur into the socket, attaching there, that acetabulum. And then we could have stuff going on in there. But so essentially what we'd want is, if you were to sit on your tennis ball or what have you, a cross ball, you'd want one here. And then you would want one more here in the hip, a little bit more in front. Think about all the adductor muscles, the pectineus, running from kind of the inside here on the front of the ischium and the pubis. And that, what it does there is it kind of rotates that hip in. Or it could actually pull that pelvis, works either way. It could pull the pelvis more ASIN, so it's that internal rotation. And that's hard for people because you're thinking internal rotation of the hip. It's not the hip, it's the pelvic structure and ilium itself that has gone internal. And we can see this arrow here jamming up the sacroiliac joint. And that's what always confused me a little bit. So I think the hip, right? But this is the hip joint. It moves independently. Sometimes it's so restricted that both are just kind of moving as one, and that's a big problem we see with a lot of people, is that there is not this isolated hip motion, and the pelvis, the ilium, side joints, the lumbar spine, and the knees are trying to help out restricted motion there. And all these little tiny muscles, you can see how this is very almost like a rotator cuff idea, and that is the problem, where we have imbalance of the rotator cuff of the hip, and that prevents good tracking in the pelvis. But piriformis ultimately is a good muscle too. It should be able to help us pull that hip into the socket, and it kind of works opposite of pectineus, which is more in the front. Think about it, both of them working together, kind of wrapping it from both sides if they're equally activated, and that's the problem. They're not equally activated most of the time, and that's causing imbalance of the muscle. But again, it could be all that tissue too, that the ligaments and the joint tissue causing restriction there. So let's look at some other muscles here. So that would be adductors, possibly tighter on the right leg. Makes sense with the internal rotation of the ilium, right? Not the hip. The hip itself could actually be posterior. Think about the ilium and hip. They tend to work opposite of each other. If it's more internally rotated on one side, that's going to force that hip, femur, to turn externally. So giving in to the piriformis's pull, if you will. And that doesn't mean that this one's turned in either. Generally, most people have trouble pulling their hips inwards, internally rotating. So that could be some fake weakness there on the right side. And sometimes you would think about it's hypertonic, it means it's stronger. Not necessarily. It means it's shorter, but sometimes we need to strengthen it in that lengthened position. And that's what the decompression stance is all about, is getting that eccentric contraction. But on the left side, probably some weakness, just because how everything's going to go. We're going to have more hamstring dominance with a posteriorly rotated ilium, and just how it's externally rotated here. So think about the SI joint opening up, which actually makes the AS, it's going to feel like the IS in the front of your hip is higher and more internal. So that could have some iliacus going on with it, but it can also, as it moves that way, here is going to be farther, more midline than it should be, putting a strain on the adductors on the left side. So we'd want to possibly stretch the right, strengthen the left, and that's going to just mirror everything we do. And once we've figured out what we are, what our pattern is, it's a very powerful tool, because then you know, hey, this is what I should be stretching, this is what I should be strengthening. And banded workouts and foundation training are really the best way to do this, because it's very active. We're just getting that stretch component, but we're also getting that strengthening component that we need to, and that can help us really bring these changes about in the pelvic structure.